So Gary, there's a post on social media that contains an article from a public integrity organization. And that article implies that children and adults with disabilities such as Down syndrome and cystic fibrosis or et cetera, that those individuals will be denied access to ventilators due to their lower overall expected lifespan should they get COVID-19. Needless to say, there are a lot of parents and family members who are angry about such a prospect in our community. Does such a blanket policy exist in California and at Kaweah Delta?
It does not, but these policies do exist across the nation. Some have been developed by the state themselves, but some developed specifically by the hospitals themselves. And they're designed to help healthcare workers make incredibly difficult decisions when you're in a public health emergency, when you literally are in a crisis situation where you have demand that far exceeds your availability of supplies and ventilators, things of that nature. And so you try to take healthcare workers out of the unfathomable position of having to decide, who lives and who dies, or who gets care and who doesn't get care. And so these policies are generally critical care and ventilator use allocation algorithms. And we are currently working on one right now. I personally am working with a group of physicians, critical care intensivists, palliative care physicians, emergency medicine physicians, nurses, on what a policy would look like here at Kaweah Delta. A policy that you hope you never ever have to invoke, but you have to plan for the worst. You don't want to be having to make those decisions in the moment without, having trained your folks and really understand how to manage through it. So the policy and the algorithm that we are creating right now is a combination of one taken from the University of Pittsburgh in Pennsylvania and North Texas Hospital in Texas. I'm kind of taking a combination of the two. The one that we are most likely to adopt uses a scoring system, SOFA. So SOFA is the clinical evaluation or assessment that's done of a patient, and it looks at different conditions of the patient, and they receive a score based on that condition, and oftentimes they're then placed into a category essentially of survival. So they end up, depending again on the condition and the survivability rate, is low priority, intermediate priority, and high priority. And they don't include any references to the or factor in anything about the worthiness of anybody's life, or even life expectancy. It really is based on survivability of the virus. And again, looking at very quantitative, specific clinical measures that help a physician make that determination. So you would never exclude a child just because they had Down syndrome or has cystic fibrosis. You wouldn't exclude them because they had those conditions. Everybody would be treated, the same, that they would be eligible for critical care services that they would normally be eligible for. But in certain situations, somebody that had metastatic cancer and the survival rate was, incredibly low. You would have to make decisions like that when you just have, so many ventilators, so many ICU beds, so many physicians that you have to be able to make those, again, incredibly difficult decisions. But anything that we develop will be very compassionately thought out and developed, and it will not take into account, the age, the sex, the quality, the perceived, societal value of anybody. It will be based purely on the conditions that the patient has and that survivability rate.